So the question is, based on the findings from the ASCENT-04 and ASCENT-03 study, how should we systematically construct a comprehensive treatment pathway for advanced triple-negative breast cancer centered on the sacituzumab and govitecan? In clinical practice, how can we individualize the selection or the adjustment of treatment based on the patient baseline condition? So what the difference exists in formulating individualized treatment plans between Chinese and European patients? So first, we want to ask Dr. Trapani to share your opinion about this question.
Yeah, thanks. This is really an important question because, as you know, the sacituzumab has been tested in a global clinical trial. So we have many data that really support safety and activity in a global perspective, including in the, Eastern Asian and Chinese population. I should say, that there are, upcoming data, emerging data that show that probably the toxicity profile of sacituzumab govitecan is determined by pharmacogenomics, in particular as it is for irinotecan, and the UGT polymorphism may affect, such a likelihood of toxicity, especially neutropenia and diarrhea. So perhaps the only, real-life data and study that I would enable and support in the Chinese population is to understand what is the distribution of the UGT polymorphisms, how these are interacting with the irinotecan, and if potentially we need to adjust the dose or identify those patients who are more susceptible to the toxicity overall. But in general, as it pertains to patient selections, it really we should really mirror the pivotal clinical trial enrollment criteria. We know that patients with metastatic triple-negative breast cancer that is PD-L1 positive, derive an important overall survival benefit with incorporation of immunotherapy, and we should stick to such a paradigm that's very established, especially in more immunogenic tumors and those that are recurring after 12 months since the initial the completion of the adjuvant treatments, and of course the de novo metastatic. While for those patients with very resistant tumors that are perhaps PD-L1 negative or recurring, below the 6 months or under the adjuvant treatments, the ASCENT-03 should support our decision with a single agent ADC upfront for these patients. I understand that the ASCENT clinical trial, they leave us some kind of thinking about how to sequence the treatment with chemotherapy and ADC, and this is really part of the real-world evidence and also reanalysis of the clinical trial, because we are so lucky that the ASCENT-04 and 03 in particular permitted the crossover of patients to sacituzumab second line, and the tangible proportion did such a shift, from the first to second line if assigned to chemotherapy upfront. So this data exists, and they will really help us to understand how to position and sequence and identify best patients in the clinical practice.
Yeah, thank you very much, Dr. Trapani. So, Dr. Jin, could you share your opinion about this question?
Okay. Dear Professor Corey-Joner and Professor Hu, thank you very much for the kind invitation. I really appreciated the insightful updates on the breast cancer therapy. It is a great honor to participate in this discussion. Based on the emerging implications of the ASCENT-04 and ASCENT-03 studies, the treatment landscape of advanced TNBC is shifting from a chemotherapy-based paradigm to an ADC-based paradigm. For PD-L1 positive patients, the ASCENT-04 study established that SG combined with pembrolizumab significantly improves the PFS compared to the previously standard chemotherapy plus pembrolizumab. Therefore, the new first-line standard for PD-L1 positive metastatic TNBC is SG plus pembrolizumab. For PD-L1 negative or immuno-oncology ineligible patients, the ASCENT-03 study demonstrated that SG monotherapy is superior to physicians' choice of chemotherapy. Consequently, For patients who are PD-L1 active or cannot tolerate immunotherapy, SG monotherapy should now be the preferred first line regimen. Since SG is utilized in the first line setting, the primary strategy for the second line treatment would be chemotherapy. For example, cisplatin, ABC, or capecitabine or eribulin. However, if the patient harbors germline BRCA1 mutations, PARP inhibitors are recommended. For patients with HER2 low expression, there is currently low evidence either supporting or opposing a switch to TDXD. Given that the panels of TDXD and SG belong to the same class of drugs, potential cross-resistance may exist. Additionally, angiogenic therapy can indeed be considered in later lines of treatment. For patients with no tumor burden, such as those with omega metastatic disease or no invasive metastasis, we would opt for a gentle regimen, such as oral chemotherapy. Conversely, if the tumor burden is significant, but the patient has a poor performance states or limited bone marrow rhythm, we would choose to adjust the dose of SG or chemotherapy agents. Ideally, if UT1A1 testing is available, it is best to identify the high-risk patients and implement upfront dose reduction. I'm not entirely familiar with international practice patterns, but I have heard this is a stronger emphasis on quality of life and performance for monotherapy. In China, we also aimed to make a balance between quality of life and efficacy when formulating treatment plans. Currently, likely due to the fact that SG has not yet been included in the national medical insurance, its accessibility is lower here than abroad. That's my opinion.
Yeah, thank you very much, Dr. Jin.